Case-based discussion session 2. CBD 4. A 13-year-old patient undergo a recent extensive bowel resection and was presented to emergency department with extensive hypopigmentation. I think you can see extensive hypopigmentation all over the body and itchy rash. Child was on total parenteral nutrition. Has undergone extensive bowel resection, and therefore, as a result, patient is on lipofundin and other protein supplements plus dextrose. On examination, looks ill, febrile, was hemodynamically stable. That means blood pressure, respiratory rate are within normal limits. On admission, C-reactive protein was 112 while procalcitonin was 2. Full blood count was neutropenia, leukocytosis with partial eosinophil. I have taken 2 blood cultures and empiric comparison B was initiated. So, what is the diagnosis? It is pityriasis vesicular bloodstream infection. How we arrive an etiological diagnosis? For that, we have taken 2 blood cultures, put them in automated blood culture machine, and so for that we need mycology, blood samples for fungi. Based on that, next day we have found that it was positive, and we have to do lactobin or cotton blue, and it shows spaghetti and meatball appearance. But to confirm that, we put culture limit, subculture limit, Dixon and go with the further identification using biochemical phenotypic testing. So it has shown that it has a spaghetti and meatball appearance suggestive of Malacisium furfur. So pathophysiology of pityriasis vesicular bloodstream infection. So this is usually pityriasis vesicular, which caused by Malacisium furfur. In addition, Malacisium symbolis, Malacisium globosa, or even more, there are 11 to 12 species. They are part of our human microbiota, most of, and also they are which cause pityriasis vesicular, which is hypopigmentation in a confined manner among immunocompetent people. So it is not a contagious disease, but it based on the humidity, temperature, and patient's sebum concentration as well as immunocompromise or immune status, it may lead to extensive lesion. Specifically, it's a saprophyte other way, and also it is a dimorphic, and also it is a lipophilic or lipophilic fungi. So when this patient, we told that patient is on total parenteral nutrition, specifically lipofundin. So this fungi has a favor to go on lipid-containing media. So when patient was on total parenteral nutrition, there is a high possibility of contamination of this lipid-containing parenteral nutrition, lipofundin. So as a result, when there is a high risk of contamination, so that could be the most possible, probable way of a mode of transmission, which leads into the bloodstream, leads to wandering around this blood circulation, leads to fungemia, that is pityriasis vesicular bloodstream infection. So discuss the rationale of empiric comparison B therapy. So this patient is, though hemodynamically stable, patient is immunocompromised. Other thing is pityriasis vesicular bloodstream infection. Though it's a superficial fungi, but in here it is bloodstream infection. So as a result, severity is high. There are virulent factors, morphological, because it has a dimorphic features as well as some enzymes. So as a result, patient is at a high risk due to immunocompromised state. So in that case, we have initiated broad spectrum, and that is amphotericin B. So there are several formulations like uh, liposomal amphotericin B and conventional varieties. Anyway, it is nephrotoxic, but rationale is to give a broad cover. Then, after isolation of the and identification of the pathogen with antifungal susceptibility, we can streamline the therapy based on the clinical response as well as markers of inflammation, specifically CRP. Procalcitonin has a less value compared to bacterial pathogens. Shall we move to the other case? That is case 5. A 56-year-old patient presented with fever and headache for 2 days. He was diagnosed with human immunodeficiency. Viral infection leads to acquired immunodeficiency syndrome, AIDS, and on antiretroviral therapy. On examination, looks ill, febrile, hemodynamically patient was stable. On admission, we did a baseline C-reactive protein. It was around 88, and procalcitonin was zero point 0.5 nanogram per liter. That is, perhaps it's at the lowest limit. So full blood count, again we detect neutropenic leukocytosis. CT brain was done because patient was presented fever and headache. Usually fever and headache is a are constitutional symptoms, but with HIV patient with headache, fever, it more towards meningitis. More often it could be fungal meningitis. So we did a CT brain to exclude papillary, sorry, increase intracranial pressure while we do the fundoscope to exclude the papilledema as well. And once intracranial pressure is not increased, it is excluded, then we can do a lumbar puncture. So lumbar puncture, and we have taken blood cultures as well. And here we have initiated empiric parenteral or intravenous flucons. Serum creatinine was normal. It's a CT brain, and we can find some lesions there, normal, like large, not a tumor, but it's called cryptococoma, not what's cryptococcal meningitis. You can see here capsule stain or indwelling stain. You can see capsulated yeast is there. So, what is the diagnosis? It is cryptococcal meningitis caused by mainly Cryptococcus neoformans. How we have arrived at etiological diagnosis? We have taken blood cultures as well as we have taken CSF, and we can put CSF into the blood culture bottle for culture, as well as we do CSF pool report, which comes with cell count. Often lymphocytic count is observed in fungal infections. In contrast to bacterial infection, we can so neutrophil count, high count in the CSF. In addition, we have to measure the proteins as well as sugars. At the same time, we have to do random blood sugar as well. And for the culture, as well as we may we may preserve a sample to do molecular studies. And next day, we have found in the culture, there was blood culture as well as in CSF was positive. And this was going on subarachnoid dextrose. And we did the India staining and found that it is termed as negative staining because surrounding India ink is black in color. So surrounding we can see black color while uh, this is the capsule. You can see this is the capsule. So capsulated pathogen, when we look to the microscope, we can see like halos around the black background. Okay, count is turning like here. So when there it is the capsulated pathogen, it's more towards Cryptococcus neoformans, but there are other varieties. This is another semi-automated phenotypic diagnostic method called analytical product index or API. Here, thing is when we are going to identify a pathogen, there may be we required to do several biochemical tests. But here on board, everything are arranged into a plate, single plate. So there are different enzymatic reactions, biochemicals are there. So once we put known amount of cryptocoral neoformans colonies, then we keep it in incubator at 35 plus or minus 2 centigrade with the room air. So next day when we see, we can see different, you see there are different reactions. So there may be different color change. So there is a barcode, I mean coding. Based on the scoring system is there. There is a leaflet. So we can get a score. And once we enter it into the software, it gives a probable pathogen. That's how it goes. This is another advanced platform. It is termed as YTech2, Advanced Expert System. It is also semi-automated. This is a cartridge. So it has bacterial diagnostic, aerobics, anaerobics, then enterobacteriaceae, non-enterobacteriaceae, and here for the fungi. So we put that particular isolate in the mixture provided by the manufacturer and mix them and insert into this cartridge and put into the machine. Over the 4 hours, within 4 hours, it gives the identity as well as antifungal susceptibility. So this is another advanced system with a semi-automated platform. Then there are other strips like lateral flow, immunochromatography test. We can use as a point of care test because it gives a color. So those are the novel diagnostics, and also there are molecular diagnostics are available, polymerase chain reaction we can do further. But in the clinical practice, if you are able to find the capsule halos on negative staining or Indian ink staining, that is enough. So about the pathophysiology, there are in the molecular level, activation of host cell pathways leading to specific phenotype types and fates. So there are molecular pathways and there are activated pathways leads to autophagy, inflammations and hepatotoxis. So when we count into the getting into cellular level, modification of cellular organization, escapes accumulation of fungal materials are there. So it interferes with the phagolysomal maturation. You know, in macrophage, as a phagosome, and there's a lysosome. Once the yeast is engulfed into the phagosome and which fuse with the lysosome, it is termed as phagolysome. So there's a this killing mechanisms are there, activation with the enzymatic lytic mechanisms, but we can also interference with the phagolysomal maturation. It's a evasion of immune evasion mechanism from the body. Disruption of the phagocytosomal membrane, that's another one. Accumulation of polysaccharide containing vesicles. Depolarization and fragmentation of the mitochondria. Once mitochondria is depolarized, energy production ability is hampered. Swelling and cytoskeleton abnormalities are leads to within the cell. Likewise, there are lytic exocytosis, activation of cell death pathways, apoptosis triggering. So ultimately, when we collect into the tissue level, disruption of the intracellular architecture, accumulation of yeast creating fungal masses. So it manifests as in the body as a dissemination, leads to meningitis, cryptococoma formation, even pulmonary infection. But among immunocompromised ones, uh, meningitis is the commonest. So what is the mode of transmission? So it is transmitted from inhalation. Spores are, it's a saprophyte against. They are commonly found among decaying debris, plant materials, and bird drooping. So when there's environmental, I mean, it spores flies over the wind and come into our body, it transmitted to respiratory tract. So about the therapy, you have to have idea about these three stages. First is induction stage. Usually it takes around 2 weeks, or amphotericin is the more often prescribed, or else we can go with the flucytosone, which is not available in Sri Lanka, or else we can go with the fluconazole. Here also we have started fluconazole. Ideally, if it is available, flucytosone combined with amphotericin is there, but this patient was hemodynamically stable, so it is easy. Then about the consolidation. So then, then about the consolidation phase, it's another next phase. So it takes around 8 weeks. Following the cure or following the response, we can give fluconazole here. Plus, if it is patient with HIV, we have to give the now we have to start antiretroviral therapy. Usually, in this case, we stop antiretroviral therapy to prevent the complication called Irish. And usually it takes 8 weeks, then maintenance therapy. Maybe more than 1 year, we can cure the fluconazole. That's how it goes. We'll move to the next case, last one. A 51-year-old patient presented to outpatient department with fever for 2 days. He was diagnosed with chronic renal insufficiency and is on regular hemodialysis. On examination, he looks ill and febrile. He was hemodynamically stable. Next, admission C-reactive protein was around 132 while procalcitonin was normal. Neutrophil leukocytosis was detected. We have taken 2 blood cultures because patient with fever, you have to take an empiric intravenous fluconazole initiated, suspecting possibility of candidemia. Serum creatinine was fairly high because it's a patient with chronic renal insufficiency. Next day, microbiology lab informed both blood cultures are positive and Graham staining and chrome finding. We can see some yeast and chrome Ega Candida albicans were detected. You can see hemodialysis is a risk factor. So what is the diagnosis? It is candidemia, and we have taken 2 blood cultures and found that gram staining and chromega. So about the pathophysiology, usually Candida albicans or even other Candida non-albicans like Gulielmodi, uh, Crucei, likewise there are a lot of organisms. So they may associated, they can be found in our body as a normal microbiota. So usually when there is diabetes, burn, neutropenia, immunodeficiencies, patient on chronic prolonged antibiotic, irrational use of antibiotic, if it is a prematurity or also associated with long lives. So it leads to modification of microbiota leading to overgrowth and mucosal colonization. So it is micro invasion is there. So here, initially colonization it leads to translocation to the circulation via long lines like hemodialysis, central venous lines. Then it leads to transient candidemia and it leads to catheter-associated candidemia, depends on the patient's risk factors. So there are multiple virulence factors. One is metabolic flexibility, hydrolytic enzymes. There are a lot. Then candida lysines. That's one of a cytolytic peptide. Then phenotypic switching, plaque cells resistant to neutrophil engulfment, biofilm formation, adherence to host surfaces, ease to hypermorphogenesis, countering host nutritional immunity, escape from the phagocytes, evasion from the host immune system. So there are several mechanisms. So there are personal predisposing factors like local dysbiosis, predisposing factor, poor oral hygiene. It depends on the patient. In our case, each patient is on long lines and on hemodialysis. So then there may be associated immunodeficiencies. Itself in the chronic disease, it leads to immunodeficiency, not only HIV, neoplasia, chemotherapy, even the chronic renal insufficiency is one. So Candida has a virulence factors, what I have mentioned in earlier. So management wise, what we have to do is first we have to assess the antifungal susceptibility. Often Candida albicans are susceptible to fluconazole based since this patient is hemodynamically stable, liver function is okay. So we have continued fluconazole and we have to do daily blood cultures until it become negative. From that day onwards, we have to give 14 days of therapy and we can monitor the response with patients' clinical symptoms as well as C-reactive protein. We better do every other day, not continuously. We don't need to do in ESR in weekly, and also we have to exclude while doing in ophthalmological examination to exclude endophthalmitis Then two-dimensional echocardiography to exclude possibility of invective endocarditis, and we have to do ultrasound abdomen to exclude possibility of cryptic abscesses to find the focus. But anyway, this patient is having long lines, so that is the most probable possible route of transmission. So these are the tests. Thank you. So shall we move to the MCQ? Which of the following is true regarding dermatophytes? This is a true false type 1. Anthropophilic dermatophytes show a strong preference to a particular body site. Yes, anthropophilic means they are favor to human. Infection with zoophilic species leads to least inflammations. Wrong. Zoophilic has more foreignness compared to anthropophilic. So once they are there, body produce extensive immune reactions, so lead to inflammation. Patient with inflammatory infections develop a secondary rash. No. Plaque hair are a specimen of the choice for infection of scalp. No. Usually when we are plucking, we may miss the endotrix or exotrix. It can detach from, break from that particular weak point. So we have to cut the hair and take them. Oral ketoconazole is the treatment of choice for toenail infection. Oral is toenail, yes, it's better. Single best response. Best statement regarding the commonest mode of transmission of fungal infection is inhalation. It's one of common. Chromatic transplant implantation can be, but it's least. Exogenous transmission of candida usually no. Chromatic inoculation of rhizospores into the skin and soft tissue, that also a possibility, but hand carriage of candida species is the commonest. And the recommended best practice in the treatment of candidemia is repeating procalcitonin daily. It's good, but not affordable. It's not required at fully. Repeating ESR every third day wrong. We have to repeat it weekly. It has a high turnover time, prolonged turnover time. Following initiation of appropriate antifungal, daily repeat in the blood culture until it becomes negative. Yes. Assessing the serum creatinine, prescribing antifungal from two different causes. No. Here you can see a OSPE, a 30-year-old patient on chemotherapy presented with low-grade fever, blood culture yield following pathogens, blood agar, subarachnoid dextrosaga, later found this is a germ tube test. So there's a constriction here. Once we put them this isolate with the serum mixing and allow to look at 4 hours after inoculation. If there's this constrictions and this tube is seen, it's termed as germ tube test, and it is a germ tube positive. So it is around 95% of candida albicans are having germ tube positivity. So it is termed as candida albicans. So it is candidemia here. Two agent useful, two agent, but we are giving separately. Fluconazole we can give hepatitis B. So this is about amphotericin B. List 2 available preparation of amphotericin B. Lysosomal is one common and conventional. There are amphotericin B, colloidal dispersion, lipid complex AB, LC here. Okay, amphotericin B lipid complex. There are other forms. All are novel formulas. Conventional is the one where it's available much in Sri Lanka, but liposomal is also available. Two adverse effects are highly nephrotoxic, and also there's a possibility of getting anaphylaxis in the first case, drug type 1 hypersensitivity. So we have to do the pre-sensitivity assessment to prevent anaphylaxis, and we have to hydrate the patient to avoid nephrotoxicity. So thank you very much.